I'm Dr. Manzar, and I'm working as a consultant here at Blackwood National. The topic that's been given to me is emergency evaluation and management of hydrocephalic patients. So, any idea what hydrocephalus is? It's going to be an interactive session. We've got 15 minutes. G. And which leads to expansion of cerebral ventricles and in babies, enlargement of the skulls, and especially the forehead and atrophy of the brain. So fluid is normal within the brain, but if it exceeds normal limits, it becomes hydrocephalus, which is pathological. The reason we are discussing hydrocephalus is because of this Manzar doctrine. Manzar doctrine essentially it establishes a relationship between different parts or different components within the cranial cavity. This cavity is, as we always know, closed cavity. Cannot expand, especially in adults. And we've got an equilibrium between venous volume, arterial blood, the brain, and the CSF. If one or the other goes up or down, the other one has to compensate. If you see here, there is some mass, which can be a tumor, which is usually not present within the brain. If it comes there, then all the other components have to compensate to maintain the equilibrium. And within a certain limit, this equilibrium is maintained. But beyond that, it becomes pathological, and the pressure is above the normal limits. Any idea about the normal CSF pressure in adults? G. Or you can set it to 16 or 18 centimeters of water. To maintain this equilibrium, one or the other component has to go up or come down. Okay. So when I talk about hydrocephalus, there are two components. There are two types of hydrocephalus. One is obstructive, the other one is communicating. Communicating means that all the ventricles, the lateral ventricle, the third ventricle, and the fourth ventricle, they're all communicating with the subarachnoid space. They're all dilated, they're all enlarged. When you're talking about obstructive hydrocephalus, it's a kind of hydrocephalus where all the ventricles are not communicating with each other. Like you see here, this is an MR and that is the CT scan. The CSF, this is the lateral ventricle, and this is the area of the aqueduct. In pediatric population, you see patients who have got aqueductal narrowing. And because of that, the enlargement of the ventricles is asymmetrical. This is the fourth ventricle, which looks normal, is quite enlarged. So this asymmetrical dilatation of ventricle is because of the obstruction, and that is called obstructive hydrocephalus. On the other hand, in patients who've got meningitis or subarachnoid hemorrhage and they develop hydrocephalus later on, they typically have enlargement of the ventricles of all four systems, the lateral ventricle, the third, and the fourth ventricles. Varies with the kind of hydrocephalus that patient has. Just to go through the common etiologies that can lead to hydrocephalus in the obstructive type, this is something that we see not very frequently, but quite oftenly. Apical stenosis, post-fossa tumors, cellular and supracellular masses. The common kind of hydrocephalus that we see in our population is mostly the communicating type, the post-meningitic or the post-tuberculous meningitic hydrocephalus, post-SH hydrocephalus. There are a couple of other varieties which are included in this definition of hydrocephalus, but not all of them are actually hydrocephalus. Ex vacuo is something that is a neurodegenerative thing, but the NPH is included in hydrocephalus. Although treatment is different from the rest of the hydrocephalus. Ex vacuo essentially means that there is some injury within the brain that leads to atrophy of that part, and the hydrocephalus, the ventricular cavity enlarges. And that is disproportionate to the cerebral mental, and that is ex vacuo. You don't need to treat that. That is because of the sequelae of something that has led to neurodegeneration chronically. However, NPH is something different. You see the cerebral mantle is relatively full, ventricles are enlarged. If you check the pressure in these patients, it is normal, but the radiological appearance is that of hydrocephalus. The exact pathology is not very clear, but there are various reasons for that. One of which is that it gets the subarachnoid space gets chronically blocked after some blockage because of previous infection or bleeding that has affected the subarachnoid component. Okay, after this initial brief preview about obstructive and the communicating hydrocephalus, manage these patients always start with history and examination. So there are a couple of history features that are important in when you're hydrocephalus or has got a shunt in place. Vomiting, lethargy, fever, irritability, seizures. Predictive value means that if in patients who've got hydrocephalus and got headache, this hydrocephalus causing the headache is about 43%. So these are the important things that you need to remember in history taking. You need to ask about the headaches, the vomitings, the lethargy, fever, irritability, the seizures, and in patients who've got shunt in place, you can ask about the feeding habits of if it's a baby, or you check for swellings if it's there, or erythema from the site of the wound if it's been recently done. When you examine a patient with hydrocephalus, it's a baby, because most of the findings are in pediatric population. In adults, mostly it's the history and few of the clinical findings, but you rely mostly on the history and the radiological findings. You see a baby who's got an enlarged head, who's got sunken eyes, and if you palpate, the fontanelle is bulging or stents. You can also appreciate the presence of prominent veins all over the scalp. And if the sutures are not closed, find that sutures are separated because of the increase in the intracranial pressure. These are a few of the findings on the head and the eye area that you can see in a patient who's got raised ICP. If the shunt is in place, do not forget to palpate the reservoir. And if possible, in patients who are thin and lean, you can also palpate the track of the shunt. If it's fractured or if it's disconnected, you may be able to identify that. Okay, after the history and examination, the next thing is to do some investigations. One of the common investigations that we usually perform is a CT scan of the brain. If you want a radiological criteria to assess whether a patient has hydrocephalus or not, these are few of the things that you look for. You look for the temporal horns beyond this 2 mm. Usually, the temporal horns are barely visible. This is an Evans ratio, which means the maximum diameter of the frontal horns against the maximum diameter of the bifrontal diameter. If you check this ratio, usually at the level of foramen of Monroe, if it's more than 30%, it means that the patient has got acute hydrocephalus. Periventricular lucencies, which means that because of the increased CSF pressure, a part of some of the fluid moves through the ependema and into the circular space, and that gives this hypoattenuated areas. This on CT, if you are looking at the MR, because the CSF on the T2 image, if CSF is white, so that black area will be replaced by a white area. You can see it on T2 images. And if you're looking at the flare image, which is essentially a T1, where the CSF looks like T1, but the edema within the brain is hyper intense. Next thing is ballooning or Mickey Mousing of the ventricles. If the frontal horns enlarge and they enlarge significantly, the term given to them is Mickey Mousing. Thing is upward bowing of corpus callosum on sagittal MRI sequences. If you look here, you'll see that the corpus callosum is not flat; it is somewhat bowing up. This is one of the features in MR. So There are a couple of other studies that you do, but before that, there are various shunts available that we can use in patients who get hydrocephalus. In pediatric population, we use these contoured or low-profile shunts in babies who are newborn, or in adults we use this burr hole type of shunt. There are devices which are called anti-siphon. The purpose of using them is in a patient who are symptomatic with hydrocephalus, and you assume or you are of the opinion that they have a siphoning effect. Use the anti-siphoning device in those patients. These valves are some of the valves are pressure dominated, pressure driven. They're low, medium, or high pressure valves. Usually in adults, we use medium pressure valve, which works okay. In a patient who's got a shunt malfunction, you need to evaluate it in addition to the CT scan. The other thing that we can do is shunt series X-rays. The idea of doing the shunt series X-rays is to look at the shunt. Second thing is that the X-rays should overlap together, because if you have X-rays of cervical spine, the chest area and the abdominal area separately, you may miss a part. So if you need to get an X-rays, it has to be overlapping. The PA view is better than AP view because it reduces the dosage to patient size. There are times when the distal end of the shunt is not working, and to assess that, there are a couple of modalities that you can use. One is ultrasound and the CT scan. They show a collection that is surrounding this distal part of the shunt, which may lead to shunt working but malfunctioning. We don't use this radionuclide studies, but people do use it to assess the patency of a shunt. This shows that when the shunt is patent or not. You put a dye in a reservoir, and then you follow it over a period of time. If it goes into the abdominal cavity within that prescribed time, that means the shunt is working properly. Complications of shunts. Shunt can have either infection, or they can malfunction, or they can be obstructed. The proximal end can be affected, or distal end can be affected, or a reservoir may malfunction. Common infections are the skin flora that are associated with shunt infections. This is algorithm or schema to look to what to do when you see a patient who's got shunt infection. You send cultures C-reactive protein to look for the infection. And if there's evidence of infection or no infection, if there is no infection, then there are other reasons for patients' lethargy or drowsiness. It may be left-right imbalance or something else. If it comes out to be infection, then you need to take out the shunt, continue with antimicrobial therapy, put an EVD in, and repeat the cultures. If the cultures are negative on 3 successive occasions, you can go and repeat the shunt again. In tuberculous men, this is for patients who've got meningitis reasons other than tuberculosis. In tuberculosis, you can save shunt, but for that you need to have prolonged antimicrobial therapy. And function, if a patient who fails to improve after a VP shunt, you can, instead of this, you can put in a CT scan or MR or other a clinical assessment. And if the shunt appears obstructed, shunt revision is the treatment of choice. But if it's malfunctioning, you need to have some sort of CSF pressure monitoring. What we do here is we use lumbar tap. If lumbar tap shows that pressure is high, it means that shunt may be not functioning properly. You change it. If pressure is low, then you may seek for other diagnosis. If the pressure is high, then you have to change it to a low pressure system. Shunt is in place, but you change the valve. If the pressure is, if a patient is complaining of headaches or nausea when he gets up and starts walking, it may be because of siphoning effect. You can use an anti-siphoning device within that shunt. There are shunts available which have that anti-siphoning device built in. But there are others that it doesn't come inbuilt. So you have to put in as an additional procedure. Coming to case scenarios, a few months back, I saw a patient who was 20-year-old male and had a headache and progressive worsening headache and had nausea. We did CT scan on that patient, and this was the finding. Any idea what's happening here? क्या नजर आ रहा है इसमें? एक तो नजर आ रहा है इसमें, आप कह रहे हैं हाइड्रोसेफेलस है, और उसका रीजन क्या नजर आ रहा है? कि कुछ यहाँ पे दाना, कुछ यहाँ पे कुछ दिस समथिंग देयर, ठीक है ना, जो ऑब्स्ट्रक्ट कर रहा है इसको. दिस एन ऑब्स्ट्रक्टिव टाइप ऑफ हाइड्रोसेफेलस. तो हाउ विल यू मैनेज इट? 2 minutes. I mean, you can put in a shunt or you can take out this tumor. I mean, the patient may not need shunt. Okay, this is a 50-year-old patient who had a progressive drowsiness and vomiting, and this is a CT scan contrast done, which shows communicating type of hydrocephalus. The patient had an LP done, which showed trace ICP. Patient symptoms improved after LP, so we put in the shunt. Okay, recently we did, I did a case, a patient who had previous shunt, and we revised the shunt, and that patient improved for a couple of weeks and then came back with drowsiness. We look at, we tapped the shunt and we did a lumbar tap on this patient, and the pressure was high. So what we did in this patient was we changed the reservoir, we changed the low pressure system, and he improved. So changing the shunt altogether might not be an option. Just changing the reservoir may help the patient. So this is something that you need to remember. This is communicating type hydrocephalus, and this non-communicating type hydrocephalus. You don't need to put in shunt in every patient. Patients who have an obstructive type hydrocephalus, and if you can take out the lesion, then you can save the patient from a shunt. Okay, thank you.